So I started out my career in television news, which is a whole different context. But then when I changed trajectory, I moved into public health. So I got a MPH degree, and then I went and got a social work degree, and I worked in HIV prevention in the 1990s. It was the height of the HIV/AIDS epidemic, and I was working in New York City, which was the epicenter of the epidemic, if you will. And during that time, I was not only doing HIV education, but doing a lot of HIV testing and counseling. And eventually, when you do that type of work long enough, you will hear stories of people about how they got to this point of being at risk for HIV. And there were a number of people, unfortunately, who I would have to give positive test results to. And ever so often, ever so often, people will express not wanting to live or a suicidal thought. And I always was caught off guard. I never felt quite prepared. I felt prepared to deliver an HIV test result. I felt prepared to talk about people's risk for HIV and AIDS and how to get care, but not around the psychosocial issues around suicide. And so I, on my own, kind of pushed myself to learn more and to get more smarter about it. And luckily, at the time, I was working for the New York Department of Health and Mental Hygiene. And we had a relationship with NYU, New York University. And they had mental health workshops that were for free. And if you know me for even 10 minutes, you know I'm just a nerd for anything free and learning. So free education. So I would catch the bus during the day, my lunch hour, to go to NYU to sit for an hour, hour and a half workshop, and then go back to work. And I had a supervisor who supported me in that. So I say that to say, so I got really smarter about kind of the fundamentals of suicide. And then over the years, my career just took me in different areas. I worked for the federal government. I worked for the state of Georgia as the director of suicide prevention, the Alzheimer's Association. And I would say the more that I got invested in the work around suicide in different populations, the more I didn't see a lot of people who looked like me. It was a career path within mental health that just really wasn't as diversified as you would think. And so that kind of brought me to where I wanted to learn more. And in my role at the federal government and being the director of suicide for a state, I got to immerse myself. And I'm so glad that I did. So it really wasn't a trajectory that I thought I'm going to start out and I'm going to do this. I really was drawn into it.
Well, I really appreciate you sharing that. And that definitely gives us a good light into your journey and helps us to kind of envision some of the more of the conversation that we'll get into as we break that down some more. You were working in New York during the HIV/AIDS epidemic. What was that experience like?
So I'm looking up, like literally there's a tape rewinding right now. When I got to New York, from Detroit to New York, Detroit and New York are very different types of cities. Both are urban, but New York had a different feeling and hustle to it. And I had never lived in New York before. So for me, I really embraced it. It was New York was a rough city because Detroit is still in the Midwest, right? It's an urban city, but it's still in the Midwest. And New York, people will tell you what they think right off the bat, right? It's a great training ground for public health. And so I soaked that up. And then I had some great mentors at the time. Like I said, supervisors who were supportive of me to if you want to go to that training, go ahead. I was starting my MPH program, like I said, in New York. I had 2 classes that were only offered during the day. That same supervisor allowed me to take the classes during the day. She said, just come back when you're done, boo. And so I say that in terms of I got a lot of support. So anything that I have achieved is not just Walker Tisdale that achieved it. There's a lot of people behind me and beside me who did that. But in terms of HIV/AIDS, it was also a very rough time because young people were impacted by HIV/AIDS and were getting infected. I remember doing outreach in Central Square, and you would see, injection needles and equipment on the ground. Things that I really wasn't used to, but your sensitivities are really shocked, but only for a short period of time, because then you still have to get into the work, right? Because people still needed the information, they needed the prevention equipment. You're talking to people about, coming to a clinic to get tested or to get information or to maybe even get more concrete services like a bed at night or to get off the street. And so that's where also I think my negotiation skills kind of got honed in a little bit because, as you can imagine from this exchange, I'm a talker. And I learned that from New York. I really learned that from New York.
Okay, well, I appreciate you sharing that. And I could only imagine it both sounds like it was great on the professional side that they were very supportive of all the things that you wanted to do and gave you flexibility in your role. And then I could only imagine just how rough and tough the situation was with the HIV/AIDS epidemic and how much you probably just learned about public health, about yourself, about so many different things that were going on.
Absolutely. I learned boundary setting. I mean, there were so many young people that I would work with who were, they were our interns and they would come in to help us to put together. We had safer sex packets with condoms and information for young people who were on the streets. And the young people that were interns would help to distribute them. And as a staff member, we would be chaperones for the young people for their safety. And so I would see young people who just would break my heart, who were in different situations
Mhm.
of vulnerability. And sometimes you hear stories about how they didn't make it or how they kind of left the city or no one has heard from them. So you kind of are left to your own devices of what happened. The same for older adults too. The homeless situation in New York at that time, this was the 1990s, early 2000s, was very dramatic. And you found that in terms of HIV AIDS, while there was medications that were coming onto the scene more, so it was more than just AZT, people were still getting infected at high rates. And so there were a lot of people who, I think there was a pivot. There came a time in prevention where there was a pivot about kind of like the Nancy Reagan, just say no,
Mhm.
abstinence. Well, that's not going to work. We need to now to kind of tailor it to where people are, right? So it became prevention, risk reduction, harm reduction. So again, a lot of my public health training really, I cut my teeth, as you would say, in New York.
Yeah, that's awesome, and I feel like I would like to like learn more about this. I was just recently reading a book, um, called "When Crack Was King," and
Mm,
and it's a people's story or retelling of the crack era in the U.S. And I think it probably has a lot of different overlaps with the HIV/AIDS epidemic. And I feel like we have a certain perception of what that was. But reading this book, it really informed me not only like Nancy Reagan, but the policies, how the over policing and like the strong on crime led to more drugs and more violence within communities and all these things. And they kind of bring it to like, we really need people with public health perspectives as mayors and in leadership decisions, because otherwise then many of these issues that are very tied to the social determinants of health and other determinants of health could be impacted poorly by some of the big policy decisions that are happening.
absolutely. I remember there was a time, I think it was, I can't remember the administration. I want to say it was the Clinton administration, but I could be wrong, that actually allowed for federal funding to be used for harm reduction. And then I think there was also, if I'm not mistaken, when I was just getting to CDC, there was a lot of investments around what we would call interventions in the box. It sounds kind of like almost like a happy meal, but is basically different interventions that were tailor made to different populations. And it was groundbreaking for at the time because people weren't really thinking about the different populations. It was a one
Mhm.
size fits all approach. And so you would have interventions for LGBTQ folks, for transgender folks, for African American, for Latino. And people could really just kind of take them off the shelf, literally, and be trained in them. And then CBOs, community based organizations, could deploy them in their community.
That's awesome. That's awesome. And I appreciate you sharing that as well.